Good morning, everyone. I'm Neil Love from Research to Practice, and welcome to Breakfast with the Investigators. As this morning, we talk about the management of urothelial bladder cancer. We have a great faculty today, Dr. Matt Galsky from the Icahn School of Medicine at Mount Sinai and the Tisch Cancer Institute in New York, Dr. Andrea Necchi from the Vita Salute San Raffaele University in Milan, Italy, and Dr. Scott Tagawa from the Weill Cornell Medicine and the Meyer Cancer Center in New York City. As we've done a number of times this weekend, we're going to refer to a survey that we did of 75 community-based general medical oncologists looking into the questions and cases they have in their practice that they would like to ask the faculty about today. Here's what we're going to talk about today. And for each one of these topics, we asked these oncologists what they wanted to ask the faculty about. We're going to start out in a second with non-muscle-invasive disease. But we were kind of chatting in the faculty room, and I want to start out with you, Matt, about one of the most pressing issues we've been hearing about all weekend. This came out in the survey, including in this part of the survey, is the lack of access to chemotherapy. I'm curious what your take is on that, particularly platinums, Matt. We saw the approval recently with EV Pembro in the first line for platinum-ineligible. I'm wondering whether or not there's situations where maybe people aren't able to access platinum. I'm wondering what you do. Are you having a problem accessing it?
Yeah, so I think this is a huge problem. Cisplatin is a important drug in bladder cancer and in a part of a curative treatment in the perioperative setting, and I would argue part of curative treatment for metastatic disease. So I think this is a big problem for us. Carboplatin as well, but particularly cisplatin. Currently in New York, there is a shortage, and we've been asked to use cisplatin and carboplatin in very specific indications, and so we are rationing it. And I think that is particularly problematic as we run into problems for treating patients in the perioperative setting, in the neoadjuvant setting specifically. The timing worked out a little bit serendipitously that as the platinum shortage was starting, EV Pembro was approved for the frontline treatment of patients with metastatic urothelial cancer are cisplatin ineligible. So there is another choice for patients with metastatic disease who you might have treated with carboplatin-based chemotherapy in the past. I think that the issue is, do you extend that and give patients EV Pembro who you would have given cisplatin? And right now, I certainly wouldn't recommend doing that in the absence of data, but if you don't have access to cisplatin, then it's not an unreasonable thing to do.
I'm kind of curious, Scott, do you think the day's coming where maybe we're going to be offering EV Pembro first line to everybody?
I think that's entirely possible. So the confirmatory trial for that combination EV Pembro is called EV-302, which is a head-to-head comparison of EV Pembro versus platinum-based chemotherapy. So gem-cis, if they're cis-eligible, gem-carbo, if they're not cisplatin-eligible, and that should be reading out in the next year or so. So that may, for decades we've used platinum-based chemotherapy, and that could replace it for patients with advanced disease.
So I'm curious, I know, Andrea, you don't really have an access problem right now to chemotherapy there in Italy. But for patients who do theoretically start out with EV Pembro who could get platinum, what would you be thinking about second and third line in a patient like that?
Yeah, good morning. First, we have a huge problem now of geographical disparity of patient access to newer therapies because outside there is clear disconnection between trial opportunities and real-world opportunities. And outside of the United States, for example, in European Union, we are still far from the availability of EV Pembro combination frontline. On the other side, we are not facing major problems in access to standard platinum chemotherapy, meaning that the backbone of chemotherapy and maintenance available will remain, at least at the medium term, as the only standard of care available in the European Union. Of course, as you mentioned, for patients who have access somehow to EV Pembro combination up front, there could be an additional opportunity to still use platinum chemotherapy potentially in the second line setting. We have very, very limited experience about this. We don't know, for example, what is the potential impact of the timing from end of first-line therapy and start of second-line chemotherapy in this case, the potential impact of additional toxicity caused by platinum, in particular neurotoxicity in patients who have been already exposed to EV treatment. So a lot of nuances, a lot of uncertainties, but as a matter of fact, chemotherapy may still be live worldwide for many years.
All right, let's talk about non-muscle invasive disease. Incidentally, here are the 7 topics that we're going to be chatting about this morning in terms of how the oncologists rated them, in terms of how much they would like to learn more. And you can see right up there at the top, neoadjuvant adjuvant therapy for muscle-invasive localized disease was their #1 interest, but also non-metastatic disease, and people are not candidates for cystectomy. A lot of interest in new agents, so many really cool agents coming in urothelial bladder cancer. We're going to try to touch on all these. But just to begin a little bit on non-muscle invasive disease, when you look at these, on the green side are the people who feel well informed about it. And Scott, as you might guess, non-muscle invasive disease is not something medical oncologists are encountering or just starting to encounter now, I think, over the next couple years. Can you talk, and also, I'm not sure exactly how much the BCG shortage is affecting, and talking about shortages is affecting the care of these patients. But right now, what are some of the options that are available out there for non-muscle invasive disease, and people have BCG resistant disease? And are you seeing patients who are being considered, have you used Pembro in that situation?
So to just kind of take a step back, I think people understand the disease, but just in
Sure,
case, most often presentations, hematuria, CT urogram typically is done to assess that, and a cystoscopy. So to diagnose non-muscle invasive bladder cancer, a good biopsy, transurethral resection of the bladder needs to be done, and generally speaking, we no longer use the term superficial because sometimes it actually is invasive until lamina propria, but to get a specimen of muscle, to say it's non-muscle invasive is important in that. And that's a mistake that can be made in the community and TURBs outside of the medical oncology field, but that's a very important, I guess arguably the most important part of the management of this disease setting. Traditionally, it was outside of medical oncology, other than maybe academic centers, as they're being sent because they're saying, oh, you should have your bladder out. What are my alternatives? Can I see an oncologist? And we would see them. But since the approval of pembrolizumab, most urology practices are not giving systemic therapy. Some are. So now it is there for the community, and there is single-arm data in BCG unresponsive. So to be BCG unresponsive, you have to get a full course of induction, which is weekly times 6, followed by some maintenance. So that has to be available and has to happen in that fashion. It's very strict for the clinical trial criteria. In the real world, we can probably be a little less strict. It's a little bit off-label, but there is a response rate and there is some durability, although most patients will ultimately have progression of disease, recurrence or progression of disease. Maybe we can use some of these exciting new agents sequentially, but the gold standard in terms of cure rate is virtually impossible to beat. Taking out the bladder is curative and essentially 100%, but then we have to deal with that.
And this is not an easy procedure. Matt, can you talk a little bit about what we know about the impact of checkpoint inhibitors and also some of the trials that are looking at other checkpoint inhibitors? We have an approval with Pembro, but there are studies going on with multiple checkpoint inhibitors.
So pembrolizumab is approved for the treatment of non-muscle invasive bladder cancer, specifically carcinoma in situ in patients who are BCG unresponsive. There's a second cohort that Andrea presented at ASCO GU, and maybe he'll update us, in patients with high-grade papillary disease. And that's a different cohort because the endpoints are different in that subset of patients. So that's technically not yet on label in the United States for Pembro. That's the single immune checkpoint inhibitor approved for the treatment of non-muscle invasive disease. And I would argue it's probably the earliest clinical disease state that any immune checkpoint inhibitor is approved in cancer. I mean, we're treating a non-invasive cancer, a carcinoma in situ. And so the impact of that, I think, has been variable, and there are some regional differences in practice. Some of the challenges there, of course, are giving systemic treatment to someone with a local problem. And anytime you do that, particularly when there's other options for local treatment, it becomes challenging. There's been interesting things happening in the non-muscle invasive bladder cancer world in that a regimen that has really not been studied prospectively, certainly we don't have phase 3 data for, has largely become a community standard, and that is intravesical treatment with the combination of docetaxel and gemcitabine. So in patients who are BCG unresponsive, that has become a go-to regimen. It's all intravesical. The response rates are pretty high. And in areas where there's a BCG shortage, we're seeing that regimen move up earlier, sometimes as initial treatment. So there's a big cooperative group study now, randomizing patients, I think it's open or open soon, randomizing patients between BCG and docetaxel gemcitabine as treatment for high-risk non-muscle invasive bladder cancer. Because of the activity of single-agent immune checkpoint blockade, like we do in oncology, everything moves up earlier. And certainly there's a rationale for combining BCG with immune checkpoint blockade. So all those trials on the last slide are for upfront treatment of patients with high-risk non-muscle invasive bladder cancer, testing the concept, should we give BCG alone or BCG plus immune checkpoint blockade? And there are about 4 similarly designed studies. We haven't seen any of the results yet, but within the next year or so, we'll probably know if there's a role for combination treatment up front.
Andrea, anything you want to say about what's been seen with pembrolizumab and the non-muscle invasive, both in the 2 subsets that Matt was talking about? And also, can you comment on this really fascinating device, the so-called pretzel, TAR-200?
Yeah, it's incredible to realize that we had to change our way of conceiving therapy when entering into the ground of urology community and patients that were managed until quite recently exclusively by urologists. And this would have meant also the need to change the logistical management of patients within hospitals and between departments. So usually now these patients or patients who have access to some systemic therapy are managed simultaneously by urologists and oncologists in 2 different departments within the hospital. This makes a huge change in the way we potentially conceive the treatment and the treatment path, the therapeutic path of the patient within hospitals in the near future. This is the first point. And the same struggle, interestingly, is being, as Matt has already mentioned, is being played in the clinical trial level because we do have on one side the data from systemic therapy alone curing these patients, and we have some signal of activity on moderate to high in certain cases activity of systemic therapy. But on the other side, we have potentially more promising data with the intravesical therapy like TAR-200 therapy in these patients. So, and we are still waiting for the data with the combination therapy. So again here, the game between urologist and oncologist maybe is likely to be win at the end with the collaboration, and the collaboration is of paramount importance also when treating patients with TAR-200. My personal feeling is that we have more chances to achieve a success with intravesical therapy in non-muscle invasive disease, but we have data in special patient population like papillary, non-CIS population with the pembro monotherapy that are equally promising. So we need more data, of course, but these are data outstanding, and these are all patients that have refused cystectomy and for which radical cystectomy is or was until quite recently the only standard of care available.
So, Matt, any thoughts about the pretzel? I guess this is a way to deliver agents through this device. Any thoughts about this approach of adding an IO to it?
Yeah,
I guess
so
tretrilimab is an IO.
It's really a fascinating device. I mean, we don't do a whole lot of device development in medical oncology, but this slowly releases gemcitabine through an osmotic gradient within the bladder. And so instead of intravesical gemcitabine, which is instilled with a catheter with a Foley, and then patients urinate it out, Obviously, the kinetics of that wouldn't be ideal for treating cancer. This is slowly released while it's in place. And the data look really good, although granted, we have small amounts of data in various clinical disease states of bladder cancer. So from the non-muscle invasive to the muscle invasive bladder cancer setting, there's some data for TAR-200 already. And you can see on the slide some of the results in non-muscle invasive disease in patients who are BCG unresponsive, which looks really quite promising. There's scientific rationale for combining this with immune checkpoint blockade, and that gemcitabine might, inhibit some suppressive myeloid elements, Tregs, et cetera. There's been longstanding literature on that, but probably more importantly, these regimens are non-cross resistant. We know both are active in bladder cancer, and they're non-cross resistant, so that's probably rationale enough to combine them.
So Scott, we get a lot of questions. I don't think oncologists are seeing that many patients at this point with non-muscle invasive disease, so they're really asking when you use it, and particularly how long you use it, also any predictors of benefit to use. And what about the patient who, maybe in their 50s, eligible, but just refuses to have a cystectomy?
So if we look at the numbers of new diagnoses per year for urothelial, actually, let me take a step back. This session is called Breakfast with Investigators, Urothelial Bladder Cancer. Urothelial carcinoma is the entire urinary tract. So there's upper tract, and I want to come back to that in terms of new ways to deliver old agents like mitomycin. But there are some features that we know are higher risk than others for recurrence and then subsequent progression to muscle-invasive disease, which can be a lethal form of the disease with eventual metastases. So carcinoma in situ, for instance, is one of the highest risk factors that is there, followed by recurrent high-grade T1 disease. So there are some factors that I would use to counsel patients, and obviously it's ultimately their choice. But again, everyone wants to have their bladder, but it's curative almost all the time in the non-muscle invasive disease state. But so that pretzel delivering gemcitabine at higher concentrations, then we can just infuse and instill in. Mitomycin is now available in a gel form, so this is approved for upper tract, so low-grade, unresectable upper tract non-muscle invasive disease, where it's able to kind of stick there. It's a gel form that then is able to penetrate a layer. So, a very smart, enriched urologist has developed a number of these drugs and devices, and is helpful because getting any BCG or any medicine to stay in the upper tract has been difficult.
Interesting. Andrea?
Yeah, for the patient safety, it's important to realize that data from the Keynote-57 presented and updated at the AUA here in Chicago 1 month ago related to the outcome of patients who have undergone radical cystectomy after the evidence of disease recurrence while on pembrolizumab therapy are very promising because the rate of disease progression or the evidence of muscle-invasive disease at the time of radical cystectomy or not positive disease was less than 10%, meaning that we have a reliable opportunity to invest on the newer therapies in this patient population without exposing the patient to an extra risk of having their disease progression or dying from a disease progression while on experimental therapy. So this is an important information to get for the near future also when testing newer therapies in this clinical context.
So, Matt, let's talk a little bit about neoadjuvant and adjuvant therapies. You saw that was the topic the oncologists were most interested in hearing about, although I think they feel generally informed, but it is a critical issue. Can you talk a little bit about where we stand today? And you updated the Checkmate 274 trial, which is really the study people are most interested in hearing about in terms of the use of adjuvant nivolumab. Can you talk about what you presented there at the GE Symposium and maybe a little bit about this study?
Sure. So neoadjuvant cisplatin-based chemotherapy, standard of care for patients with muscle-invasive bladder cancer who are cisplatin-eligible. Historically, in patients who have received neoadjuvant chemotherapy and have residual T2 or higher disease in their surgical specimen, we haven't had a lot of good options. We know that that's a poor prognostic indicator, but no adjuvant therapies had been shown to be beneficial in that post-neoadjuvant chemotherapy space. In addition, we know that a lot of our patients are cisplatin ineligible. They can't receive cisplatin. And so we've really had no non-cisplatin adjuvant therapy for patients who didn't receive neoadjuvant chemotherapy but had pathological T3 or higher disease in their surgical specimen. And so that's what Checkmate 274 was really meant to address, both of those unmet need populations. This was a big randomized study of adjuvant Nevo for a year versus placebo with a primary endpoint of disease-free survival. And it was a co-primary endpoint, disease-free survival in the all-comer population and disease-free survival in the subset of patients with high PD-L1 expression. And you'll remember for the nivolumab program, it's PD-L1 expression by the 28-8 assay with tumor cell scoring, so probably not exactly the same as the CPS report that you might be getting from your pathologist. And here you see the co-primary endpoints. This is distant metastases-free survival shown here. DFS was the primary endpoint, hazard ratio of 0.7 for 7.1. For the all-comer population, 0.53 for patients with high PD-L1 expression. So that led to FDA approval of adjuvant nivolumab. This is extended follow-up, really with much longer follow-up compared to the initial publication. We see that the effect size remains very consistent. And not only for the co-primary endpoints, but all of the secondary endpoints, the effect sizes are almost identical. Disease-free survival, distant metastases-free survival, non-urothelial tract recurrence-free survival. The effect sizes are all very similar. We haven't seen overall survival from this study yet. It's an event-driven analysis, and we haven't seen the number of events to do the analysis yet.
Andrea, any comments about the clinical use of Nevo in this situation? Do you generally follow the trial design and eligibility in terms of when you offer it? And what about PD-1 low patients?
Yeah, it's interesting to realize that for the first time we have a different label of the drug between the United States and the European Union. In the European Union, we are allowed to, and we have the possibility to use the adjuvant nivolumab in the PD-1 positive tumor alone, and not and just for certain countries because the disease actually reimbursed only for certain countries within the European Union. It's interesting to realize that if you look at the subset of the patients who benefit the most from nivolumab, adjuvant nivolumab therapy, there is the population of patients who have received some chemotherapy neoadjuvantly. So ideally, the optimal patient population that may benefit the most from this kind of therapy, potentially also with the PD-1 negative tumor, is the patients who have been exposed already to some chemotherapy neoadjuvantly. But of course, there is an ongoing debate regarding the framing of this data into the context of the other similar studies that provided the same design. For in particular, the IMvigor010 with atezolizumab, which was negative in the ITT and the PD-1 population, and we are still waiting for the potential tiebreaker of the Ambassador study, which is currently comparing pembrolizumab versus observation in the same patient population. So we will see at the end. I think that the newer data that will come from this third study, the Ambassador study, will be instrumental for us to understand a bit more regarding the role of adjuvant therapy, adjuvant immunotherapy, and we also have data, we will also have data from studies that are ongoing that are targeting the entire perioperative therapy, so studies that are providing chemoimmunotherapy upfront in the neoadjuvant setting and the adjuvant tail after radical cystectomy. So we will have also this data to contextualize into the therapeutic options.
So Scott, there were a lot of questions from the oncologists about the negative IMvigor study and also about like new directions. So first of all, we were talking about TAR-200. I'm curious about your thoughts about its being used in localized disease. But also another thing that oncologists are hearing about in almost every solid tumor, cell-free DNA, which I think was looked at in the IMvigor study, and whether maybe that might be something that's going to be used in the future. Any thoughts about, again, TAR-200 in muscle-invasive disease, and maybe the use of cell-free DNA to help sort out these adjuvant decisions?
So, traditionally, when we have, say, locally advanced solid tumor, whatever the disease is, and we want to give perioperative chemo or whatever the agent is, the main thought process is to eliminate micrometastatic disease with the local disease control kind of as a surrogate for response to that. That being said, clearly the main part of the disease is local, and if we can do something to enhance that, I'd say in particular with some other combination that might be synergistic, such as with immunotherapy, as Matt mentioned, that has some biologic rationale. Oh, and the cell-free DNA. So cell-free DNA is useful in the advanced setting in terms of picking drugs. We'll talk about that a little bit later. But in terms of monitoring minimal residual disease, a number of different diseases, colon cancer I think has been out there the most, looks very useful. And assessing that in some of these adjuvant studies points towards the patient population retrospectively that may have the most benefit. So Matt is leading a taxpayer-paid cooperative group study that hopefully will open relatively soon that's going to be based on intensifying therapy in that patient population or de-intensifying if there is no evidence of any cell-free DNA that's there.
Matt, do you want to comment?
Yeah, I was just going to make a plug for the study. Thanks, Scott. So this is called the Modern Study. It will open within the NCTN within the next 6 months, and this is a study in patients, same population as Checkmate 274, adjuvant treatment, but in patients who have detectable ctDNA after surgery, they're randomized to adjuvant Nivo, standard of care, versus adjuvant nivolumab plus LAG-3 inhibition with relatlimab. In patients who are ctDNA undetectable after surgery, they're randomized to standard of care nivolumab versus monitoring with initiation of nivolumab if they convert from undetectable ctDNA to detectable. So really asking an escalation question and a de-escalation question.
Awesome. What a trial. Great. Andrea?
Well, I think that one of the most profound impact that the ctDNA analysis might have in this patient would be the reconsideration of the need for performing radical cystectomy in selected patients, because a struggle of today's research is related to the fact that we provide very active, very effective systemic therapy, or more and more effective systemic therapy up front in the neoadjuvant stage. Patients come to a reassessment of the disease with the ctDNA negative tool, with the negative CT scan, negative MRI. So the one natural question that the urologists are raising is, shall I operate these patients, or shall I give radiotherapy to this patient, or are we able to spare the patient radical cystectomy and to spare the patient the bladder by avoiding radical cystectomy, or potentially avoiding also chemoradiation or radiotherapy in these patients? So I think that in the near future, the number of patients for whom the question that will rise regarding the need for radical cystectomy or any radical local therapy in the primary tumor will be higher and higher, because of the fact that we are providing more effective systemic therapy up front.
That's really a fascinating vision for the future. Actually, leading into the next topic, Scott, I'm curious about your clinical approach. Normally, when we talk about sparing the bladder, I think about older patients' comorbidities, but even more exciting to think maybe in the future we could spare the bladder in people who would be eligible to have it. But today, right now, Scott, I'm kind of curious how you approach, again, the older patient with comorbidities who's really not going to be a candidate for cystectomy.
Yeah, to again take a step back, in optimally selected patients, young, healthy, it appears that chemoradiation is more or less equal to cystectomy in terms of cure rates, long-term disease-free survival. So it's not only, but it is, a disease that is managed and dominated by urologists, and they deal with that. But so the point is, it's not just for the older patients. In older patients or patients with comorbidity, I think that there are challenges in administering what we think is the optimal systemic therapy, cisplatin, for instance, or combinations, 5-FU, mitomycin, et cetera. So there's reasonable single-arm data for single-agent gemcitabine, for instance. So if I'm looking to resensitize in someone who is healthy enough to get some sort of systemic therapy for radiosensitization, I think that is an option.
Andrea, can you talk a little bit about how you approach the older patient, not a candidate, for cystectomy?
Yes, I think that we have a very positive experience in managing these patients with immunotherapy in this clinical setting. Of course, the only point that is remaining is the phase 3 data. And waiting for this phase 3 data, of course, there is an opportunity for investing on newer therapies, so investing in combination therapies. And again, it's interesting to realize that paradoxically somehow, major changes have been made within trials using cystectomy as the backbone for therapy, but well, quite less changes have been made, quite less movement is ongoing by using radiotherapy as the backbone for treating patients as a backbone for the treatment of the primary tumor. So this is a matter of fact. So we do have chemoradiation standard as a standard therapy option, but within trials there is still a clear disconnection between the opportunities the patient would have in using radical cystectomy as backbone as compared to the opportunities by using chemoradiation. This is a point to discuss with the patient that usually come to us asking for something new, asking for immunotherapy, asking for EV-pembro, asking for newer therapies upfront without potentially any standard of care, chemotherapy or cystectomy.
So let's talk about management of metastatic disease. We'll start out, Matt, with first-line therapy. We've had the Javelin data out there a while, chemotherapy followed by avelumab. Is that still your usual go-to strategy? Any comments about using that? How long do you keep the avelumab going? And what kind of tolerability issues, if any, do you see with avelumab different from other IOs?
So it still is a standard of care survival benefit. One of the only recent phase 3 studies in the metastatic setting in urothelial cancer to have a survival benefit, and the effect size was quite large. So I think this is standard of care. The profile of avelumab slightly different than some other immune checkpoint inhibitors with regards to infusion reactions, but typically those are manageable and non-serious, and otherwise the same side effect profile that you see with other immune checkpoint inhibitors, which is that for the majority of patients very well tolerated, and then a subset of patients, of course, will have immune-related adverse events. The optimal duration of treatment hasn't been well established. We did a similar study, a randomized phase 2 study with switch maintenance pembrolizumab, which also met its primary endpoint, which was progression-free survival. In that study, we fixed the treatment at 2 years, but I find that patients who are doing well on immune checkpoint blockade, it's somewhat hard to stop. There's a subset of patients who want to stop, but in my experience, most patients don't. Cooperative group study was initiated to try and answer this question in terms of can we stop, and it couldn't enroll enough patients. So I think this is a difficult question to answer.
Any potential role for cell-free DNA there?
Yeah, I think it's interesting. There's at least a few investigator-initiated studies seeking to determine whether or not we can use ctDNA as a guide for who needs maintenance and when to stop maintenance treatment.
So let's talk a little bit about antibody-drug conjugates in urothelial bladder cancer. And Andrea, I'm always referring to bladder cancer as the great example of ADCs. You have 2 ADCs now approved in bladder cancer, enfortumab vedotin and sacituzumab govitecan, which is also approved and used a lot in breast cancer. We're going to talk a lot about that tonight. Can you talk a little bit about what about these 2 agents? How they're constructed, particularly what's seen in terms of tolerability issues.
Yeah, these are part of the newer wave of the revolution of post-immunotherapy options in patients with metastatic UC. Of course, enfortumab vedotin, of course, is endowed with a higher response rate, with more robust data, because we do have already phase 3 data as monotherapy as compared to investigator choice chemotherapy from the phase 3. So the 40% response rate is still something that has to be beaten in these clinical stages. Sacituzumab govitecan has been at the bit earlier disease development stage. Of course, we are still waiting for phase 3 data in the third line setting in patients who have experienced chemo and immunotherapy. The data from the randomized phase 3 TROPiCS-04 study are still awaited. But we have an interesting point that is related to the fact that we can potentially use both of these options in sequence because the payload is not the same. MMAE for enfortumab vedotin, the SN38 for sacituzumab. The target is not the same. Nectin-4 on one side and TROP2 on the other side. There is initial data suggesting that the potential suitability of using SG in EV experienced patients, or potentially vice versa, we don't know. So the point for the monotherapy use will be related to the use of this drug as a sequential strategy. Of course, as you mentioned, we do have a potential issue of safety. Another good point is that they have a completely different safety profile. For EV, the major point, at least at the long run, for using this drug are related to the neurotoxicity and the skin rash and cutaneous toxicity, meaning that multi-specialist approach is often required, is often recommended in these patients. And on the other side, for SG, we do have the potential issues related to neutropenia and diarrhea. So these are overall points that are asking for a continuous education for physician, education on one side of using this patient, of handling the side effects at best, and requiring a multidisciplinary, multi-specialist collaboration since the very beginning of the therapeutic journey on these patients.
So Matt, can you elaborate a little bit more in terms of the tolerability issues you see with these two agents, and particularly in terms of enfortumab, what the typical onset of peripheral neuropathy is, when you see it, what you do about it?
So a couple of things to know about enfortumab. If you haven't used it much, we all carry these sort of tricks or pearls with individual drugs. So the things with enfortumab are that there's a cap in the dose based on body weight. So it's important to know that that's in the label. For heavier patients, you certainly don't want to go above that cap. The second is that there's in the label a hold parameters for the glucose on the day of treatment. A glucose at 250 or above, you hold treatment. There are patients with no pre-existing diabetes who can run into problems with hyperglycemia with enfortumab. It's not common, but it can happen. So that's another pitfall to avoid. The third is that the skin toxicity ranges from something that's a nuisance to something that's life-threatening, and it's somewhat hard to sort that out early on without seeing patients. And so, the drug is given when it's given as a single agent, day 1, 8, and 15 on a 28-day cycle. And you want to look at patients, in particularly the first couple cycles. When you see them once a month, you might not be looking at the skin quite enough, or have an advanced practitioner take a look at the skin. The neuropathy tends to be problematic around month 4 to 6, maybe a little bit earlier in some patients. Certainly doesn't happen right away. And it's a little bit different than cisplatin or oxaliplatin-related neuropathy. You see a little bit more motor effect. And so it's like with all the drugs that we use that cause neuropathy, it's just vigilance, education, dose holds, dose delays. I would say one of the things with these drugs, and it's somewhat anecdotal, but I think it's a recurrent observation, that holding treatment does not mean progression in the short term. And we see patients off treatment for months, and a few for years off treatment without progression. And so certainly patients who are responding to treatment oftentimes don't want to hold or stop treatment when they're running into neuropathy, but you can reassure them that oftentimes these responses will be maintained even if you're holding treatment for a period of time.
Any clinical pearls in terms of tolerability issues with sacituzumab, Matt? And what do you do if the patient already has significant pre-existing neuropathy, or any times you would put sacituzumab before enfortumab?
So for someone with a lot of neuropathy from prior cisplatin, I would use sacituzumab before enfortumab, but the neuropathy has to be, affecting daily function. The pearls for sacituzumab, many of you have a lot of experience with sacituzumab in breast cancer. I tend to use growth factors early. We treat an older patient population in patients with urothelial cancer who have had prior platinum-based chemotherapy often, sometimes multiple lines of treatment. So I tend to use growth factors from the start, and I would say that's probably the biggest pearl.
One of the things that's interesting is I guess there's no correlation between TROP2 and benefit, Scott, with the use of sacituzumab. I guess in breast cancer there's no correlation.
So yeah, so this year at ASCO, there's two analyses on biomarkers with sacituzumab govitecan. One is on the target, which is TROP2, and using H-scores. So two things. One is that in urothelial carcinoma, it's almost always high, the expression levels. But then within that higher range, there's no real difference in terms of efficacy, looking at response rate, progression-free survival, overall survival. And then the metabolism of the toxin SN38, like irinotecan, is via UGT1A1, and looking at that polymorphism, there are trends. So there's numerically higher adverse event rates, more dose reductions, but nothing that stands out incredibly. That may be because of low numbers. So when we pull the data together across breast cancer, other indications, it looks, the data are there that in someone who has a UGT1A1 2828, it's homozygous for the polymorphism, there's more myelosuppression. It's not necessarily more diarrhea. There's the experiences that we don't necessarily need to test for that, but I think that most people are aware there is an association with that polymorphism and Gilbert's disease. So if we're seeing indirect hyperbilirubinemia, just kind of keep it in mind. And I always see the patients, or at least advanced practitioners, on day 15 of cycle 1. And that's when we'll know how much diarrhea they're having, how much neutropenia they're having for subsequent cycles, but it's especially the neutropenia if they happen to have that polymorphism.
Wow, that is really interesting. I've not heard that. All right, so let's talk about platinum-ineligible patients. And Andrea, of course, the really exciting option of EV plus Pembro, which again just recently was approved as a first-line therapy. Platinum-eligible patients. Anything you want to say about what we know about this regimen and your experience with it, Andrea?
Yeah, it's clear that the data from this cohort, the response rate, the PFS, survival data are clear, outstanding, and potentially practice-changing pending the data from the phase 3 study, DV302, which has compared the EV Pembro combination with the platinum chemotherapy. Of course, it's more than likely that it would be an option worldwide, so accepted by the community outside of the US also. There is still uncertainty regarding the eligibility, as we have already discussed, the eligibility of the patient to EV Pembro combination, because we have, and Matt has done a lot of work trying to identify criteria, for example, for cisplatin eligibility. We know much less regarding eligibility to other drugs like carboplatin. We don't know basically which are the features defining the population who may be defined as platinum ineligible, and we currently don't know, and we don't have neither biomarkers related to that may help us to identify the population who may benefit the most, who may be well suited for EV Pembro combination. So the struggle against between chemo for certain patients and EV Pembro combination is still live. There are different safety profiles. So very promising data on one side. So no question about the efficacy. A few questions regarding the safety profile for the combination that may allow us to tend towards chemotherapy in certain cases, and waiting for additional data for more selected patients, like biomarker selected patients with targeted therapy.
Matt, any comments about this strategy? Again, a younger, very healthy patient who says, quality of life-wise, how about if I take a shot at this?
So the response rate in the pooled cohorts is 68%, so a pretty high response rate for a population of patients with metastatic urothelial cancer, and the duration of response is quite long as well. So I think it's a very effective regimen, probably the most effective regimen. It's been developed in bladder cancer since platinum-based chemotherapy. For young patients with lymph node-only disease, lymph node-only metastatic disease, I still worry a little bit that we don't know the long-term outcomes with a new regimen like this, and we know that a subset of patients treated with cisplatin-based chemotherapy, probably particularly with switch maintenance immune checkpoint blockade, will have very durable disease control and even potentially will be cured. And so I think until we have comparative data in a cisplatin-eligible population, I'm certainly hesitant to use it. Although again, like I stated earlier, in the setting of a cisplatin shortage, if you were pressed to use this regimen versus something else, I think it makes sense to use this regimen.
I guess the other thing you were saying before about stopping enfortumab because of neuropathy and having to reassure the patient that it's okay to be off therapy. Here, I guess you keep the pembro going.
That's right. That's right. So built-in maintenance.
So Scott, let's talk a little bit about FGFR and erdafitinib. We're seeing some interesting data here at the meeting about this. First of all, can you provide a little bit of an overview about what these alterations are, how we pick them up in terms of assays, and what we know about these inhibitors?
So overall, urothelial cancer is the most common cancer that's going to have an FGFR alteration, although as you can see here on the slide, it's more often in papillary non-muscle-invasive disease. In metastatic disease, it's probably around 15%. The most common alteration in urothelial cancer is an FGFR3 mutation, unlike cholangiocarcinoma where it's a FGFR2 fusion. That being said, they're both there, and whatever assay is being used should be able to assess both mutations as well as fusions. That is available in some plasma tests, and obviously in tissue too. Luckily, for urothelial cancer, if it happens, it tends to be early. So even going back to this cystectomy specimen, for instance, if a metastatic biopsy is difficult, it's probably reliable there. This is probably, I don't know if this is the first one, this is the longer-term follow-up for the initial study that led to the accelerated FDA approval of this drug. So activating FGFR3 mutations or FGFR2/3 fusions, single-arm study selected. Most were previously treated, although cisplatin-ineligible could get it frontline. And you can see the nice waterfall plot, 40% response rate. Literally as we speak, the phase 3 study confirming this, I'll tell you, beat chemotherapy in the previously treated patient population. So I suspect that's going to lead to the full approval. I think it's probably not as important in the United States because we have access, but to get it available kind of worldwide. So I think there's two main points. These are listed here. So one is that if we don't check, it's 0%. So it's around 15, you can say it's only 15%, well 0% if we don't assess for these genomic alterations. Most of the FGFR inhibitors are pan-FGFR, so particularly when you hit FGFR1, but just forget that. Phosphorus goes up, it's a pharmacodynamic marker. It usually is not such a big deal, but that is in the regimen. If phosphorus doesn't go up and there's no other AEs, we should titrate up to 9, and there's some data that they do a little bit better if that happens. But besides that, it's just because it's a targeted pill does not mean there's no toxicity. So oral stomatitis toxicity, hand-foot, diarrhea, fatigue, nail changes, and then what I think, it was on the other slide, what I think a lot of people are most scared of, I think because we're not used to it, is eye toxicity. So central serous retinopathy is not that common, although eye problems overall are common, but in the label, it's a baseline comprehensive eye exam, which can be done by optometrists or ophthalmologists, at least in the United States, followed by monthly for the first 3 months and then every 3 months thereafter. There is some kind of quick and dirty screening that can be done in Amsler Grid. You can just look that up, AMSLER, which is basically graph paper. And you cover one eye and look at the other eye. And if things become blurry, that's a reasonable screening test that maybe they need to see an ophthalmologist sooner.
So I'm just flipping through some of the trials, looking at this and also ongoing. Andrea, any comments on the practical issues of tolerability? When you sit down with a patient and start erdafitinib, what are some of the things that you're going through with them? What are some of the things you're looking for in their first few weeks of therapy?
Yeah, the issues of tolerability of erdafitinib may come at the long run, in particular the cutaneous toxicity, the retinopathy issues, nail toxicity, meaning that for in patient for whom you should use this drug at the long run due to the fact that you are using the drug earlier in the disease stage, there might be problems in the tolerability. It's clear that we have another option, and hopefully, based on the Thor data presented today, another option approved in countries outside of the U.S. Currently, erdafitinib is not approved in the European Union, but the other point is also the other point potentially amplifying the geographical disparity is also related to the fact that the companion diagnostic is still an issue. So the access of the patient to tissue biopsy or liquid biopsy, so the access to the possibility of having the tumor or the blood circulating tumor cells assessed for this mutation is still an issue in the real world, and we don't know what is the right timing for assessment of FGFR receptor alteration in these patients. So there are still issues that should be solved when translating the data, the clinical trial data into the real world, partly related to the safety profile, of course, and I would say more related to the use of erdafitinib in earlier disease stage as compared to post-chemo and post-immune therapy like the Thor study. And the other point is access to the companion diagnostic and to the genomic test for FGFR receptor alteration.
Yeah, Matt, in terms of sequencing here in the middle there, you see a doc has a 65-year-old woman who just progressed on first-line chemo. What do you think about in terms of sequencing of erdafitinib? Would you give it before a checkpoint inhibitor? Would you give it before enfortumab? Does it matter whether the patient's symptomatic or not? And also any pearls about using the drug tolerability-wise, Matt?
So the responses tend to happen pretty quickly. It's sort of classic oncogene addiction. You use this regimen, and usually by the first scan, if there's going to be a response, you see a response. Sequencing of immune checkpoint blockade versus erdafitinib, one before the other from a scientific standpoint, there's some rationale for sequencing. From a practical standpoint, I don't think it probably matters. I tend to use in patients who are getting platinum-based chemotherapy and switch maintenance immune checkpoint blockade, in the presence of an FGFR alteration, I tend to go to erdafitinib next. It's an active drug, and I find that patients oftentimes welcome a break from an infusional therapy. In patients who haven't had immune checkpoint blockade yet but have platinum-based chemotherapy, it depends a little bit on their sites of disease and pace of disease. If it's a little bit more indolent, lymph node predominant, then I tend to use an immune checkpoint inhibitor first.
Any pearls about phosphate management? That's not something that oncologists are usually looking at. And also any pearls about the nails, fingernails?
In terms of the FOS, obviously frequent monitoring, just remembering to monitor it is one pearl. In the guidelines per the package insert, and if you use UpToDate, they're in UpToDate as well, are really straightforward in terms of when to hold, when to add a phosphate binder. And so it's relatively cookbook. You just have to remember to check for it. The skin and nails can be challenging, and I think probably most important that you need to warn patients about this from the start. If you have a good dermatologist to get involved, that's always helpful, but probably doesn't totally require that. You need patients to inform you as soon as they're starting to develop this, because it can become painful very quickly, and patients can oftentimes lose their nails. And so similar to the discussion about enfortumab vedotin, there's a little bit of a learning curve, but I think the name of the game is early recognition, holding treatment, and dose reductions. And patients can do well on erdafitinib at a lower dose than the starting dose. There's also parameters for increasing the dose in the package insert. based on the FOS that's achieved. In practice, I haven't encountered that commonly that I'm able to do that, but that is a possibility as well.
Really amazing how often oncologists are using drugs for the first time. You know, it's really incredible. So many new drugs out there. You need to be ready the first time to use it. Looks like that could be happening with HER2-positive urothelial bladder cancer. Scott, can you provide a little bit of an overview of what we know in terms of incidence of HER2-positive urothelial bladder cancer and some of the really interesting strategies that have been used in other cancers and some like the Satamab that haven't in terms of HER2-positive disease?
In terms of the prevalence, it's partly dependent on how we define HER2 positivity. I guess it's now happening across different diseases, so anywhere from a quarter to over half, depending on how we define it. We've had some evidence going back to some trastuzumab combinations that there's some sort of a signal, but with the advent of the ADCs, there's now multiple ADCs, including one that has breakthrough designation that are targeting HER2. So we know it's a good target across different types of cancers. We know that as a cell surface target, ADCs can work as we have multiple approved drugs, not for urothelial. So it makes sense. This is the one on the bottom right is the one that has breakthrough designation. This one here.
Hertuzumab, I love that name. I haven't seen that before. Hertuzumab, cool.
Yeah,
how does it work?
I always make it complex for us up here to stumble across. That's why we use our abbreviations. We say EV and SG. So anyway, I think it's a good target. An issue with this particular drug in the context of EV, so it's the same payload, MMAE. So, different targets. I think there might be the ability for some sequential use. And I don't have data to say this in terms of comparisons, but at least SG versus EV, they're different targets and different payloads, as Andrea mentioned. This is a different target, but the same payload, so that could be an issue.
So, Matt, any comments about it? Looks like pretty interesting outcome, a response rate 50%, really interesting looking waterfall plot. Any comments about this? So does it work with HER2 low? Of course, tonight we're going to be talking about TDXD, which also has been looked at in bladder cancer. And there you see responses in people who are HER2 low. Any comments on this agent, Matt?
So with disitamab vedotin, one of the interesting things is that the antibody is actually not trastuzumab. It's directed against a different epitope on HER2, which is different than some of the other HER2 antibody drug conjugates. Mostly has been developed in China, so it's also an unusual setting where we actually have lots of phase 2 data already for both the single agent and the combination from completed studies in China, and now we're trying to replicate those results in international studies, and you see the results from pooled studies in China here. Response rate that's quite respectable in patients who've had prior platinum and oftentimes more than one prior treatment. And the combination of this drug plus toripalimab, PD-1 inhibitor as upfront treatment yields response rates pretty similar to what we see with EV Pembro in a study in China. So there's enthusiasm for this regimen.
Have you actually used this agent, Matt?
In clinical trials, I've used this regimen. There's a very large phase 2 study that includes DV alone in patients who have progressed despite prior treatment, and then DV plus Pembro as upfront treatment for treatment-naive patients.
And what have you seen in terms of response and tolerability?
So the responses are encouraging, anecdotally, and I think in line with what we've seen from the data in China. And the tolerability is different than EV, at least so far. And maybe this is in part related to the fact that there's nectin expression on the skin, potentially related to the skin toxicities that we're seeing with enfortumab, but we're not seeing a lot of skin toxicity with disitamab.
And finally, of course, we're hearing about already this weekend, we talked about TDXD in lung cancer, upper GI, colorectal, and of course, breast cancer, also biliary tract cancer. Andrea, what about urothelial bladder cancer, TDXD?
Well, I think that in general, given the fact that the competition has become very, very high in the metastatic UC, I think that it is good to have targeted therapy, so a development path that is focused on biomarker selected patients. Regarding the PARP inhibitors, the story is still at the very beginning. The initial data from the Bayou study and the two main in the cisplatin-ineligible population with the immune combination, or with the use of PARP inhibitors as single agent in the maintenance therapy in the two studies, the Atlantis study and the smaller Italian Mituro study, tell us that there is an opportunity primarily to look at these drugs in combination with immunotherapy, and maybe better in biomarker-selected patients, so patients whose tumor has some kind of HRR gene alteration. But we are still at the very beginning of identifying the right HRR gene alteration, whether or not BRCA2 is BRCA1 and 2 are the only biomarker to use in the spectrum of HRR alteration for these drugs, or shall we use these mutations to select these patients or not, and the combination therapy. So major question to be solved as of today. Promising response rates and then PFS reported mainly in the Atlantis study, but still very, very difficult to envision a future based on the fact that there are current developments with other drugs like ADCs, as we discussed in the same clinical setting. So very, very difficult to tell at this time, but good to have a personalized medicine approach, a biomarker-selected approach in these patients.
I think that's a great way to end this. So thank you so much to the faculty. Thank you for attending. Call them back here tonight, 7 p.m. We've got a lot to talk about in breast cancer. Have a great day. Thanks.